First of all, thank everyone for taking the time to join us this evening. As you know, this is a continuation of a series of conversations that I'm putting together primarily for my concierge patients, but I'm very happy that everybody else can also join and get benefit from these discussions. I try to bring in some of the latest changes that is in the field of medicine, and this session particularly is going to be about diabetes type 2. Not to make this too long, again, I just like to kind of give you an overall view. There is going to be maybe a lot of details. If there is any questions, please feel free to ask me. You could just maybe wait till the end of the slideshow. I think that would be the best time to ask questions, and then we can kind of stay on the subject. This talk should be about maybe 35 minutes, maybe 40 minutes, depending on how much conversation we're going to have. But let's talk about diabetes. Diabetes is basically an elevated blood sugar. I'm sure a lot of you guys are familiar with diabetes, either as a personal experience or someone else that you know. Diabetes is basically a disease that affects how your body handles the blood sugar or the blood glucose. So it is a metabolic disease. Basically, two causes of diabetes: either the body doesn't produce enough insulin, or insulin is not doing the proper work, which means it's not really lowering the blood sugar appropriately. So it's kind of what we call either insulin resistance or insulin malfunction. Diabetes in the United States, let's look at the prevalence. About 30 million people. Some of the statistics may be a little bit old, maybe about 5 or 6 years old, but these numbers kind of give you an overall view of what's happening. So about 30 million people have diabetes. And when we talk about diabetes, we're talking about adult onset diabetes, or we're looking at type 2 diabetes. So almost 1 out of 11 people in the United States has diabetes. Now, this is different than pre-diabetes. So we'll talk about the description of what is pre-diabetes and what is diabetes. And interestingly, 1 out of 4 people that have diabetes don't even know that they have diabetes. So again, a lot of people don't have enough information about it. This shows the trend of adult onset diabetes in adult population. So we're looking at adults in ages between 18 and 79. You're looking at 2 graphs here. You're looking at the prevalence and incidence, almost the same thing. But as you could see, somewhere in the late 80s, early 90s, we're going to see an increase in the prevalence and incidence of diabetes. And the next slide will also shows that there is also definitely a predisposition for certain ethnic and racial backgrounds. So American Indians, Alaskan natives have the highest incidence of diabetes. The whites and the Hispanics have Asians and the whites have the lowest incidence of diabetes type 2, and the blacks and the Hispanics fall somewhere in between. So these are the genetic variations. As far as diabetes and risk factors, when we look at United States map, this is a map of the United States as far as incidence of obesity. We're looking at 1994, we're looking at 2000 and 2010. Unfortunately, we don't have data on this slides on more recent maps, but it's going to be very similar. So as the incidence of diabetes has been increasing, it's related to the obesity in the United States. So as the obesity increases, the incidence of diabetes as well. Now, some of the northern states are a little bit less, some of the southern states are a little bit more, but overall, that's going to be completely related. Now, let's talk about the types of diabetes. You hear that all the times. There's type 1 diabetes, which is primarily in children, or this is what we used to call the juvenile onset diabetes. The juvenile onset or the type 1 diabetes, which is a new name, is approximately 5% of the adult form of diabetes. This is because of insulin deficiency. This is mainly because the pancreas is not producing insulin anymore. Or in the old times, they used to call this insulin dependent. That means without the insulin, patients die. So very important, but again, this is not part of our conversation tonight, and maybe down the road, we'll talk about that. Let's talk about type 2 diabetes. The old name for that was the adult onset diabetes or type 2 diabetes or non-insulin dependent diabetes. Bottom line, majority of the patients, about 95% of adult population have this type of diabetes. So this is because of three reasons. Number one, there may be decrease in insulin production, but at the same time, there is going to be insulin resistance. At the same time, we're also looking at too much production of glucose or the blood sugar from the liver. So it's a combination of multiple things together. So again, just a quick reminder, most type of diabetes, again, 90% of adults have type 2 diabetes. And this kind of goes over the same thing. Again, if they call it adult onset or non-insulin dependent, they are talking about the same thing. So what happens to typically everything that we eat? So majority of what we eat is carbohydrates. Carbohydrates, of course, they break down into glucose, and that's how they get absorbed through the intestine. That's how they get transported in the bloodstream, and that's how they enter into the cell. So in a normal individual, without insulin, the glucose cannot get into the cell, okay? So basically, when we eat something, your body produces the right amount of insulin, and it produces it at the right time to be able to get that glucose into the cell, okay? This slide kind of shows two things. It may be a little bit confusing and maybe hard to see, but let me just show you a simple thing. So this is your pancreas that produces insulin, okay? And of course, insulin causes absorption at the same time, transport of glucose into the cell. So the blood sugar that we see comes from two sources. Number one, from intestinal absorption of your food. And of course, the other component has to do with the liver that produces some of that glucose. So as you know, liver stores the glucose in a form that it can break down. For the times that we are fasting, that's where the storage is. And if for 24 hours, your liver can actually break down the storage and produce glucose. In high blood sugar, so this is a condition we call hyperglycemia or prediabetes, okay? So in prediabetes, basically two major factors. Too little insulin, not enough insulin is produced. The cells may have some resistance, so they cannot really use the insulin property. And also, actually, liver produces too much of the glucose. I'm going to show you a graph. This is a little bit busy, but bear with me. So again, these are the factors that create a pre-diabetic phase. And so if you see this line, this is a line that separates the pre-diabetes to the left and the diabetes to the right, okay? So this would be your blood sugar line right here. So as people develop more diabetes, for example, this green line is the insulin level. So in a pre-diabetic, the insulin can actually go up and be able to control the blood sugar. But as time goes by, you can see that insulin production decreases because the pancreas becomes very fatigued, or pancreas gets old, or actually decompensates. So eventually we get to a point that your body does not produce enough insulin. As a result, what we're going to see with these two lines, these are your fasting blood sugar or the postprandial, which is after meal blood sugar. So gradually they do increase. The other thing that develops over time is the insulin resistance. So Yeah. So as much as the insulin goes up and stays up, but the insulin resistance continues. So basically, insulin is not doing exactly what it's supposed to do. And one more thing is, this is the hepatic, this is your liver glucose production. As you can see, the liver production is very low, but in the diabetic phase, it's just the opposite, it's high. Your blood sugar is high, and liver should not be producing any glucose, but it actually does. So these are some of the abnormalities that we can see with diabetes. All right, let me show you one more. Actually, there is a slide that's coming up. So let's look at the risk factors for diabetes. As you know, there are what we call non-modifiable risk factor, and then we have the modifiable risk factor. The non-modifiable risk factors are basically the race and ethnicity, which is basically nothing we can change. Age, unfortunately, we cannot change that yet. Family history of diabetes, very important factor. And of course, history of gestational diabetes, of course, that's in individuals that have had pregnancy that are complicated by diabetes or high blood sugars. But the part that we really pay attention to is going to be the modifiable risk factors. So physical inactivity, very important factor. High body fat or weight. So again, very important factor. As the slide that I showed you, it showed that as the incidence of obesity goes up, of course, the incidence of diabetes type 2 also goes up. High blood sugar, high blood pressure and high cholesterol. Again, these are all risk factors that when you put them together, they create the condition, what we used to call syndrome X. We still use that diagnosis, and maybe you've heard of that. It's basically all these factors combined that are interrelated that increase the incidence of insulin resistance and complications for cardiovascular disease. So let's look at the diagnostic criteria. How do we know if somebody is diabetic or pre-diabetic? So we look at a couple of different tests. As you know, and I'm sure all of you have heard of A1c. A1c is short for glycolated hemoglobin. It's basically a hemoglobin in your bloodstream that has a blood sugar attached to it. It's a percentage. Basically, your hemoglobin, which is a measure of your red blood cell, because there is sugar present, part of that hemoglobin has blood sugar attached to it. In a normal individual, that's a percentage, and that's less than 6.4%. So that way we can kind of look at things over time and take a look if your numbers are below 6.4 or 5.7 for normal individuals. So 5.7 or lower is going to be what we call a normal value. 5.7 to 6.4 is a pre-diabetic. Over 6.5 is a diabetic range. You can also look at the fasting blood sugar. The fasting blood sugar below 100 being normal. 100 to 125 is the pre-diabetes. And then anything over 126 is in the diabetic phase. We also can make diagnosis of pre-diabetes or diabetes with what they call the oral glucose tolerance test. That is basically the test that we used to use that a lot. We don't use it very much. We use it mainly maybe in the, in the obstetric category when we're trying to find out if somebody that is pregnant have a predisposition for diabetes. So that's really something the GYN, OBGYN uses the most. We don't really use that because our criteria is pretty good with A1c. And then, of course, we can always use a random plasma glucose. The random plasma glucose is basically what it is. It says it would be a blood test that's usually done about an hour, 2 hours, or 3 hours after a meal. And that by itself can give you a little bit of understanding of what's happening to the blood sugar in a form of prediabetes or diabetes. So these are actually the criteria that we use. Let's take a look at some of the symptoms of hyperglycemia. First of all, not everybody develops symptoms of hyperglycemia. But if they do develop, these are some of the ones that you can definitely see. Fatigue and being tired, and that's because the body is not able to utilize the blood sugar properly. You all know that people that are diabetic, they have wounds that don't heal well, particularly in the lower extremity. Sudden weight loss, because as the blood sugar is high, the cells don't have enough sugar inside. So basically, because there is not enough insulin, the sugar is not able to get into the cell. So a lot of that sugar circulates in the blood, eventually gets dumped by the kidneys, but overall, the patients go through weight loss. Frequent urination, which is something that a lot of people actually have. That goes along with, of course, being thirsty all the time. We call that polydipsia and polyuria. Again, very, very common, drinking a lot of water. Blurred vision, one of the, again, another finding, which is the eye findings. Sexual problems definitely can happen, very common, especially, of course, in men. Always being hungry, because, again, as you are eating and consuming the food, again, most of that sugar does not get into the cell, so the sense of hunger is going to be very much present. A couple of other things that are important: vaginal infections become very prevalent. So a woman that shows up with frequent yeast infections is usually a manifestation of diabetes. Numbness and tingling, which has to do with the neuropathy that develops in the feet. So again, some, not everybody has all these symptoms. Some they have mild, 1, 2, or maybe more. But overall, these are the symptoms that could be a presentation of diabetes. Let's take a look at the complication, which is really what doctors worry about. Complication of diabetes fall into two categories mainly, as far as the vascular disease is considered. So again, we worry about vascular disease. Again, it's a very common diagnosis, common complication of diabetes. So we call that a macrovascular or microvascular complication. So macrovascular basically means large blood vessels. Okay, these are the blood vessels that provide blood to your brain, to your heart, and the extremities. So when you are obstructing the blood flow to the brain, so of course you're increasing the risk of stroke, mini stroke, and of course cognitive impairment, memory issues. The heart, everybody almost knows about this, that people have coronary disease associated with diabetes. So again, that's going to be a risk factor. Extremities, as far as large blood vessels that provide blood flow to the tissue. So this is going to be very important. As far as wounds, wounds do not heal very easily in the lower extremity. And at times they may have to do bypass of the lower extremity arteries. So these are the large blood vessels. The microvasculature, these are the smaller blood vessels. Again, mainly the capillaries. These are the smallest blood vessels that exist in the body. The organs that are involved with that would be the eye. So particularly the retina, that is the area in the back of the eye that gets affected by the microvasculature from diabetes. As you know, your doctor will be asking you to see your ophthalmologist and get a full eye exam every year, particularly to make sure that the retina is intact and doesn't see much evidence of damage. Kidneys are very important. Kidneys are almost 100% made of capillaries. There are about 1 million nephrons. Those are the units of capillaries that make the kidneys. So we're looking at a lot of small blood vessels in the kidney that can get affected, and kidney disease and renal failure is a main, complication of diabetes that we worry about. And of course, we call that the nephropathy. One more thing, and that is the neuropathy, which is different than this area. The nerves in the extremities, in the hands and the feet also require blood flow. The blood flow for the nerves also come from the capillaries. So if the capillaries get affected, then we see the nerve damage. So the nerve damage, which we call neuropathy, particularly in the lower extremity and the feet, is usually as a complication of what we call microvascular, disease associated with diabetes. So very important factors. So let's kind of talk about that. Just one quick slide as far as the incidence of these complications are clearly much higher in higher risk population. We talked about some of those would be, of course, in the Hispanic or American Indian, or in general, they call those the minority. So those complications much higher, about 2 or 4 times much higher in those populations. Actually, this is a summary of the slide that we talked about. Let me kind of bypass that. It's kind of a little redundant. Let's talk about prediabetes. Again, prediabetes is a condition between full diabetes and normal blood sugar. Again, if your blood sugar is between 100 to 126, that's called the pre-diabetic phase. How many people in the United States? About 86 million in the United States actually have a condition called as prediabetes. 30 million people have diabetes. Okay, so the prediabetes actually has a higher percentage, and majority of those people may not even be aware of, the fact that they have prediabetes. Okay, so this is, it says diabetes, but this is really a pre-diabetic phase. These are the diabetics. So overall, this is going to be a portion of the population that's at risk and has to be recognized and treated appropriately. So diabetes prevention, what can we do for prevention of diabetes? So as you know, because this is very much weight dependent, so keeping the weight under control, it becomes a very important factor. Usually when we see patients, most everyone is above their ideal weight. We measure that, of course, based on the BMI. And we emphasize that the BMI need to be closer to 25 to 27. So most people really require about 5 to 10% weight loss. Exercise is going to be utmost important, actually. Lack of activity, as we talked about, was one of the major risk factors. So starting a moderate exercise, which usually means 30 minutes of exercise per day. And exercise doesn't have to be going to the gym and pumping iron. It could be anything as far as walking, fast walking, or some form of bicycle riding, anything that will keep your muscles going and be able to burn some calories. And of course, most important is going to be selection of your food as far as the type of food that you're consuming, which would be lower in carbohydrate, more in lean proteins, and more in vegetables. Again, I'll go through a couple of slides with that so we can get an idea of what to do. So this goes with the early diagnosis, and at the same time, treatment of diabetes is very important because it does increase the longevity of the individual. People that have type 2 diabetes in general will live about 10 years shorter than anybody else that doesn't have diabetes. So by treating that, we can actually increase the longevity, quality of life, and of course, productivity. At the same time, of course, the long-term costs. So that's one of those things that is important to the government. So let's talk about how we look at these factors. So again, the ABCs, they call them knowing your A1c. A1c is an important factor. I'm sure most your physicians, healthcare workers check that for you, especially if you've had some kind of a pre-diabetic phase. Checking the other risk factors, such as the blood pressure, is extremely important. Remember that the individuals that have diabetes or pre-diabetes, the standard of their blood pressure is going to drop. So most everyone, we want their blood pressure to be less than 140/90. But once you have diabetes or prediabetes, that standard drops down to 130/80. Okay, so you want to make sure that you keep your numbers lower. Same thing happens with the cholesterol and the cholesterol component. The LDL, for most people, used to be less than 130, which dropped down to less than 100. And now the new recommendation is that if you have diabetes or prediabetes, your LDL should be less than 70. Okay, LDL is your bad cholesterol, and that should be less than 70. HDL, of course, is your good cholesterol. You want that as high as possible. So over 50 for men and over 40 for women. Okay, so that would be actually very important. Then triglyceride, we definitely want that less than 150. Okay. So again, these are good things to know, especially if you are at risk. Let's take a look at this thermometer, which is a very good way of correlating the A1c with your blood sugar. As you can see, these are the blood sugars on the right-hand side. Okay, these are the ranges, but these are the actual blood sugar. This is the A1c. So let's say the important A1cs that we pay attention to is 6. A1c of 6 correlates to an average of 126 on the blood sugar. A1c of 7 correlates to about 154. Okay, based on American College of Diabetes, the recommendations are that patients should be less than 7. Most physicians probably don't follow that. They like to get the A1c lower than that. They like to see it less than 6.5 or even less than 6, if possible. That means they want tighter control. But based on this graph, if you're below 7, you're in control. Okay, so that's a little controversial, but at the same time, you can get an idea of where everything kind of falls in. I had a patient this morning, came in with a A1c of 8. A1c of 8 actually was 8.3. Not a very good one, not a very compliant patient. That means an average blood sugar of 183, which is not very good, of course. This graph also shows the relationship between A1c and the risk of complications, particularly the things that are important. As you could see, A1c of 6, you have the lowest incidence of complications. A1c of 7, we start seeing this graph going up. So retinopathy, this is the one that has to do with the eye. Of course, retinal disease. And the red is nephropathy, which has to do with kidney disease. Neuropathy, which is, of course, the nerve irritation, numbness, tingling of the feet and the hands. And microalbuminuria, which is another manifestation of kidney disease, which is going to be down here, but very important factors. So as you can see, at 10 is almost 4 times incidence of having, let's say, retinal disease, eye disease, 4 times higher with a A1c of 10 than A1c of 7. Okay, so A1c becomes very important as far as evaluating and treatment of diabetes. Diabetes, again, it's a self-management disease because majority of the treatment is based on individual. The meal planning is very important. The activity planning is very important. The medications, of course, is with the supervising of the physician. The home blood sugar monitoring becomes very important. Follow-up appointments is very important. Some of the also other evaluations like foot care is also important, that the could be self foot care or be referred to specialists, same as skin and dental care. Let's actually talk about this just a little bit. So diabetes educators are, again, very important. And that could be your physician, that could be a nutritionist or dietitian. So if people are not quite comfortable with the type of diet that they have, they can always seek some help from dietitian to be able to come up with some kind of a program where it can give them appropriate amount and the appropriate type of foods. Self-monitoring, there are multiple ways of self-monitoring, but the most common one is, of course, the glucometer. You know how to use that. Again, very, very simple to use. It's a strip that you put inside the monitor, and it can actually measure your blood sugar very easily. And based on the criteria of postprandial, meaning after meals or before meals, you can determine where your blood sugar is falling. Diabetic follow-up every 3 months. Every 3 months, usually doctors like to see you. They like to check an A1c every 3 months. They like to check a blood pressure every 3 months. Every 6 months, we like to do a blood lipid panel, your cholesterol panel as well. Sometimes we can extend that to a year, but typically every 6 months is more reasonable. Foot care and of course, dental care should be every 3 and 6 months. And then, of course, there are other things that come in, such as the physical exam, at least once a year. So, but the important part of this slide is that A1c management should be every 3 months when you see your physician. What are the benefits of exercise? Exercise does a few things. It actually decreases the insulin requirement. So if your body is producing X amount of insulin, your requirement of insulin can come down, which means that your insulin resistance comes down. That means your body becomes more sensitive to insulin and it's going to respond much better. It does decrease your blood pressure. It increases your pancreatic function. It decreases mortality, decreases cardiovascular risk. And also, at the same time, it does affect the other lipid components. So very important. And again, we'll talk about how much exercise in the next slide. A very complicated slide, but 2 things you can get from it is that at least aerobic exercise, meaning some kind of walking or treadmill or bicycle, at least 150 minutes of moderate intensity exercise a week. Okay, 150 minutes. However, you want to divide it up in 3 days, 4 days, 5 days, but 150 minutes of moderate exercise. So most people say, what is moderate exercise? Moderate exercise is something that gets your heart rate up between 100 to 120. Okay, so that's pretty much moderate exercise. Okay, so and then also 75 minutes of intense exercise each week. So for most people, intense exercise would be closer from 120 to about 140 heart rate, okay, to be able to get your heart rate up higher and be able to maintain it for about 10 minutes. Okay, so that would be quite adequate. Now, again, these are almost what we call minimum requirements. Okay, now doesn't mean everybody has to go only 150 minutes, but again, this should be the minimal amount that everybody's comfortable with. Let's talk about something that may be a little complicated, but it's important. Type 2 diabetes medications. What do they do? So the drugs that we are talking about is going to be mainly oral medication, with an exception of a couple of these drugs that are injectable. What do? They affect the absorption of the sugar from your intestinal tract, okay? So if you have high blood sugars, you don't need to absorb a lot of sugar. So a lot of them decrease the amount of sugar absorption, okay? The other thing that they do in the liver, they decrease the production of the sugar from the liver. So if the liver is producing too much sugar, it will shut it down. One of those drugs that work in that category, you've heard of metformin. Metformin is one of our very good agents. It's been around for a long, long time. Actually, I think it was discovered in 1940s in Germany, and they already knew that it had blood sugar lowering property for many, many decades, but they never used it till I think we came into the 1990s or 2000. So bottom line, a very good drug. It's available in a generic form in multiple names, and it does a great job. It decreases the production of the sugar from the liver and also increases the uptake of the sugar in the muscle. So the muscle can actually utilize more of the sugar. There are a whole bunch of medications that increase more of the insulin production from the pancreas. These are what we call sulfonylureas. And then there are some non-sulfonylureas, secretagogues. Basically, they produce more of that. A class of drug called GLP-1s, we'll talk about that. DPP-4s, probably a lot of you guys are using one or the other. The other one, of course, would be drugs that work on the kidney. These are the drugs that inhibit the reabsorption of sugar. That means your kidneys are filtering the sugar, but that sugar needs to be reabsorbed normally. And your kidneys reabsorb all that sugar almost 100%. There are drugs that interfere with that process. So as the kidneys are dumping, as they are filtering the sugar, they will dump it in the urine. So a lot of sugar actually gets dumped. These are the newer class of medications. You probably have heard of those class. Those are drugs that what we call SGLT2s, Invokana, Farxiga, Jardiance. Maybe you've heard of those, and they do a great job. At the same time, they do cause weight loss. So very important. Unfortunately, you cannot use that class of medication with people that have renal insufficiency per se. That means the kidney function is not optimal. And of course, drugs that enhance not only the effect of insulin, but enhance the uptake of the sugar by the muscle. So there's a lot of muscle in our body. So if we take up more of the sugar into the muscle, of course, you're going to lower the blood sugar. Those are thiazolidones. One of those drugs would be Actos. If you remember that drug, we still use that drug a lot. And of course, metformin has the same effect. So let me actually go through a couple of the general medications that maybe you guys have heard of or maybe taking. Again, GLP-1, some of the best drugs we have in the market right now for diabetes, because not only they lower your blood sugar, they increase the insulin sensitivity. That means they reduce the resistance of the insulin. At the same time, they cause weight loss. One of them is Victoza. Probably you've heard of Victoza. Bydureon, one of the older drugs. We still use that. Trulicity and Ozempic would fall into this category, and I'm sure you've heard of those. Second to that would be DPP-4s. They're becoming less popular now because this class took over this class. They do almost the same thing, but in a better way. So GLP-1s are now number one. DPP-4s are probably number 4 or 5 as far as where they fall into the category of where we use them. Januvia, one of the important drugs in that category, if you remember, Onglyza. Nesina never took off, but these are the two important ones that are still out there. SGLT2 inhibitors, they work through the kidneys, as we talked about. Jardiance, probably number 1 in the market right now. A lot of cardiovascular benefit is also coming up with this. Farxiga and Invokana are also available in the market. Sulfonylureas are the older drugs. Again, Amorol, Glucotrol, Diabeta, Glinase. Any one of these guys we still use because they're very effective. But again, they don't have all the benefits of the other classes. So they're not really some of the priorities that we use right now. Insulin, of course, long-acting insulin, short-acting insulin as an option for type 2. Usually late in type 2, when there is no more insulin production, patients become what we call insulin dependent. At that point, they need to use insulin. And again, it would be a combination of short-acting and long-acting insulin. We have combination drugs. You've probably heard of some of these, Combigliza or Janumet. And of course, the glucophage or Fortamet, of course, the number 1 on the list. So I'm sure a lot of questions come up on that, but we'll talk about it. Let's forget about insulin, okay? Insulin is a complicated topic. I don't want to go too far into it. Let's talk about the type of food that a diabetic should be looking to add or subtract from their diet. Let's take a look at a meal planning. This actually may be a good thing. Meal planning should be, of course, based on what you like to eat and drink, but at the same time, take a look at a dish A typical plate, you would just cut that in 4 pieces. Half of that should be vegetables, which have low glycemic control, and a fourth of it should be starch, but we'll also talk about the type of starch because some of them will actually have higher glycemic index, and of course, meats and protein. So let's say a fourth protein, a fourth carbs, and then 50% would be on the vegetable side. And why is that important? Because as you could see, carbohydrates will give you a significant increase in the blood sugar, particularly in a 4-hour period, compared to the proteins and compared to the fats. So we really like to see less of a spike. We like to see more of a plateau. So the proteins provide that. And of course, we don't want to have too much fat in our diet. So we kind of want to stay away from fats. But as you can see, they do not give that, what we call the sugar spike. Let's take a look at actually, this is, let me look at this one. This is a better slide. I don't know how much of it you can see, but it looks at the glycemic index. Glycemic index is really a measure of how fast, let's say, a carbohydrate or a protein or anything breaks down into glucose, okay? A good glycemic index, let's say, would be less than 50. That means that food component doesn't break down very quickly. So I was looking at this, and again, my diet is as bad as most diets out there because, I like a lot of watermelon, which has got 72 glycemic index, which is pretty high. That means it causes a lot of glucose spike. Same thing as a pineapple. Pineapple is 66. Now, grapefruit, for some reason, is 25. That's awesome. An apple is 38. A peach is 42. Orange is 44. Grapes are even 46. I mean, grapes, you're talking, there's a lot of sugar there, but still not as bad as pineapple and, watermelon. Look at the vegetables. Vegetables are extremely low. Those are the great numbers. Those are what you really want is low glycemic index. Peanuts came out very good. Let's see, a lot of beans came out very good. But the worst ones, look at the worst ones. A white bagel, 103. White bread is 100. Taco shells are 97. Oatmeal, I was surprised with oatmeal of 87. Baked potato, 85. So looking at numbers, you can, again, not a lot of people know about this, but gradually, if they look at this, they can kind of change their diet from white bread to maybe, whole wheat bread. At least you come down from 100 to 71, and of course, you can change your regular potatoes from 85 to sweet potatoes, 61. So you can make some changes in your diet that actually helps that glycemic index. Again, glycemic index is exactly what we are trying to correct here because, again, as you could see, that high spike gets you, even though your average blood sugar may stay in a normal range, but then that spike will take you into the high blood sugar or pre-diabetic category. So definitely we want to have more of a spike or more of a plateau like this rather than a high spike like that. Okay, so hopefully that is a little bit clear. And this is really what we want to do. We want to change our diet from this picture to this picture, even though this one tastes a lot better than that. But we definitely want to go with something like that. So a lot of beans, some nuts, of course, fish, chicken product, and the way you prepare them also, instead of fried chicken, maybe baked or barbecued, but definitely less of the more delicious stuff, okay? So there is another component that I was going to talk to you about was the choosing your fats wisely. Again, another topic that has got a lot of importance, but little complicated. In general, what you want is you want more of unsaturated fats rather than saturated fats. unsaturated fats or polyunsaturated fats are usually liquid fats. Okay, look at, so mainly oils that are liquid at room temperature. So you want to stay away from lard or fats that are solid at room temperature. Those are the ones that are more atherogenic and create more problems with your blood vessel down the road. So that's why we kind of fall into this category. And of course, consider using more omega-3 supplements and foods that are higher in omega-3 than omega-6. And as you know, omega-6 is the atherogenic or pro-inflammatory fat. It actually causes more inflammation in your body. The omega-3 causes less inflammation in your body. And then sometimes they call them prothrombotic. That means omega-6 causes more blood clot formation. Omega-3 causes less blood clot formation. So again, very important factor. We'll hopefully talk about that down the road, but that's going to be very important. So again, less fat, but if you choose your fats, make sure that they are what they call mono or polyunsaturated rather than saturated fats and cholesterol.